Good evening and welcome to Economics Unbound. Tonight we discuss an issue that's very close to my own heart, and I suspect Nana's electronic one too. In economics, there is a special category of products and services called public goods. These are goods like public broadcasting, which I wake up every morning to do, the court system that dispenses and operates justice in our country in the interests of all, or education, which in some societies is considered a public good. These are basically products or goods or services that save lives or improve the general quality of a society. Such goods cannot be left to the whims of the market or profit makers, or society will be worse off, or so some say.
Such goods tend to be publicly funded through taxation. Public goods are such that if one person has access, his or her use and/or enjoyment of benefits from the goods are enhanced by other people having access to it too. So tonight, Thandeka and I will discuss a product that does not yet exist. That product is the COVID-19 vaccine. We dial up the volume on those voices in society that argue that a future vaccine should be a public good, universally and freely available to all humanity, rich or poor, rural or urban, first world or third world, young and old. Good evening.
Now, Nana, let us offer an example. Some time ago in Madagascar, there was a measles outbreak. That became an epidemic. The number of deaths passed the 1,200 mark. Most of those who died were children. In Madagascar, the cost of one shot of measles was so high above the reach of ordinary citizens that families would carefully consider which child would be immunized and which child would not be offered the benefits of immunization from measles. I read also concerning this example that the average family income there at the time was $2 per day, and the vaccine was around $15. Now, you can imagine how many days would the family have to pool resources to afford just one shot of the pricey vaccine to save a child's life.
This is heartbreaking, Thandeka, and it does reveal much about the economics, ethics, and sociology of medicine. You, Thandeka, have two siblings, a brother and a sister. Do you think that your mother would have chosen you for the vaccine? Huh? But the Madagascan scenario is tragic, and policy and medical ethics should have kicked in. Policymakers should have declared a measles vaccine to be a public good, paid for through taxation and available to all. This approach would have been informed by the belief that health is a key factor in the promotion of the economic growth of the country and the rise in domestic incomes of each household in that economy. But there are South Africans who've teamed up with other groups across the world to argue that a new COVID-19 vaccine should be a public good. A study at Harvard found that a government that offers vaccines for free and universally realizes certain savings. Such governments are able to avert the costs of treating critically ill people and managing huge pandemics, which we can tell is costly. There are productivity cost savings too. Let us listen to this clip in which our colleague Desiree Chauke speaks to Umunyana Rugege of NGO Section 27.
The Treatment Action Campaign and MSF, Doctors Without Borders, and as well as patient advocacy groups such as the South African Depression and Anxiety Group, the Cancer Alliance, a range of organizations that really work on the front line to try and get people access to healthcare services.
You'd already started this, but just break down for us what you foresee to be the problem should the law continue as it stands.
Sure. I think it's important for us to understand that we already have a legal framework around patents. We have a few problems with those laws, and we've been calling for the amendment of those laws. We've been in a process for the last 10 years of amending those laws, and 2 years ago, Cabinet approved an IP policy that really prioritized public health. And we are now looking forward to the draft legislation that should be coming out. And we've also called for the prioritization of that legislation to be promulgated as quickly as possible. And one of the issues that we have raised is that we have a depository system of patent application. So if a company wants to get a patent on a technology, they just simply apply and comply with very administrative processes, and they're awarded a 20-year exclusivity. Now, what we're saying is that because we have that system currently, we should, as a priority, put a moratorium on all new patents. And I think we're in agreement with the government because President Cyril Ramaphosa last week signed on to a letter, along with other African leaders and leaders from around the world, calling for any vaccine that comes out. And as you know, there are over 100 current testing clinical trials for a vaccine, that any vaccine that does emerge anywhere in the world should be patent-free. And we understand that because we know the current system prioritizes profits over public health. And there are many people around the world, activists and governments, talking about the problem with that system and the fact that that system does not work in a global pandemic, and that we need greater solidarity from governments, richer governments, as well as from the private sector. And so I think we are in agreement around the need for patent-free technologies that will ensure that there's greater access, because the price point is not fixed by the pharmaceutical company if there are no patents.
Now, besides price, access to vaccines and who gets it first when it comes out is a global conversation at the moment. How influential is this coalition in terms of steering those decisions?
So I think that our Fix the Patent Law coalition has worked in solidarity with a range of civil society organizations around the world that are all pushing for very similar things in their own countries, because the current system really does prioritize profits. And what we're saying is that we can't, as African countries in particular, and low and middle income countries around the world, we can't be at the back of the queue when a vaccine does come through. There are many companies working very hard. There's a lot of money being spent. But I think importantly, we should note that there's a lot of public money being spent on trying to find a technology that will work and that will eventually be a global public good. And I think that there's this moment now globally where we're saying we need solidarity, because we've seen what happens when treatment is not available because it's too expensive. We had an HIV epidemic in this country, and people died because they could not afford the price of antiretroviral treatment. So we've been there, we've done that, and we had that fight. Now the fight is to ensure that the technologies that come out in relation to COVID, which affects everyone in the world, is available on a needs basis rather than on the basis of countries and people that can afford it. And the great fear is that rich countries may hoard that kind of technology or vaccine or treatment and keep it from getting to the countries that actually need it.
Now, with a government that's juggling priorities in the fight against COVID-19, have you had any response in terms of the conversation you wanting to start from government?
Well, we've been engaging with government for a few years in relation to the intellectual property policy, and we've had a good working relationship with the DTI around these issues. So this is an ongoing conversation that we're having with government. In particular, we've reached out to the president, and in terms of timing, we put out our statement at the same time that President Ramaphosa signed on to this letter that calls for an agreement at an international level that will ensure patent-free vaccines. And we would go further to say it's not just the vaccines, it is any kind of treatment. And there's a lot of kind of research and development going on around the world to try and find what treatments will work. And I think, there's 7 billion people in the world. we're going to need more than one company and more than one drug and more than one vaccine to be able to reach every person in every country that needs.
So in this time that different governments, especially our government, has called for solidarity, how are you reaching out to the innovators? Are they open to the possibility of relaxing their patents?
Well, those conversations are happening globally, I think. And some of these pharmaceutical companies are talking about pooling the technology. And there is an organization called the Medicines Patent Pool that is also engaged in these conversations. And they have successfully created a pool that will allow for technologies to be used, the knowledge around the technologies to be used by generic companies, so that more medicines are available to the people who need them. So those conversations are happening at different levels between governments and companies. They are working with foundations such as the Wellcome Trust. And so there are many kinds of conversations, coalitions. Different pharmaceutical companies are working together. So there's that kind of solidarity in the private sector as well, which we welcome, to ensure quicker progress in finding solutions and health technologies that will work and stop people dying.
Let's thank you for talking to us this morning, but mostly, how can the public take part in this process of engaging government?
I think, these issues are very complex, and we've tried to break down this information so that people can really understand and engage with the topic. You can follow the Fix the Patent Laws coalition online on all social media platforms, as well as Section 27 and the Treatment Action Campaign. We are putting out a lot of information so that people can understand these issues and how it impacts on our country's response. And people are engaged at different levels in our country's response and should be engaged also on future treatments and vaccines for South Africa and for other African countries.
That was very interesting, Thandeka. Did you know that the Hippocratic Oath is an oath of ethics historically taken by doctors and is as ancient as the hills, having its origins between the 5th and 3rd centuries before Christ? It also promotes universal, non-discriminatory access to the benefits of medicine and healing. But it also promotes confidentiality and non-malice, or goodness. So really, I cannot stand doctors involved in stealing and preventing universal access to life-saving PEPs.
Oh, Nana, you're getting political now. Yes, Nana, the oath says something like, that's the ancient oath. I swear by Apollo, the great physician, and by Panacea, and all the gods and the goddesses, making them my witness, and I will carry out, according to my ability and judgment, this oath and this indenture, and so on and so forth. But I do not wish to go down that rabbit hole of medical ethics now, because I suspect that my next guest will likely correct me. Good evening, Dr. Kgosi Lehlape.
Good evening to you and the viewers.
Was I making you nostalgic there, reciting the Hippocratic Oath? At least the ancient one.
Yes, but we now have a physician's pledge,
Yes.
which is the latest iteration to come from the World Medical Association.
Now, how do physicians feel about vaccines as public goods?
I think most of us feel health should be a public good. If every citizen of the globe has to get the health care that they need, good quality, irrespective of need, all aspects of healthcare should be global good.
Now, medicine has become a big money business, and a lot of overprescribing, a lot of patents, a lot of money, a lot of middlemen selling medical equipment, medicines, and so on. How do you think the idea or the move to have the new COVID-19 vaccine be a public good would land in this highly commercialized, highly monetized context of ours in South Africa?
I think it becomes an opportunity to pull back on the industrialization of health. Health can't be left to the marketplace, and professionals can't be surrogates for industry. So professionalism needs to be brought back so that healthcare professionals throughout the spectrum are incentivized for professionalism and do not make money from trading of goods, so that all of us as professionals can ensure that the goods are made accessible to all that need those goods.
And of course, Doctor,
Now, part of the issue that would probably need to be considered is the fact that states and governments should step up to funding research through academic institutions so that the IP could then be in the public domain.
Now, public goods are traditionally funded through taxation, but the pharmaceutical industry has been working very hard to develop vaccines that can save lives. Why would you crowd them out of the game if it became a public good? How would that relationship between the pharmaceutical industry and the state sector work with regards to a COVID-19 vaccine becoming a public good?
I think the states and the people should come back to taking collective responsibility for the health of the population and stop outsourcing that responsibility to the market. If you look at what has happened over the last few decades, the people and the state have underfunded research. So it's been left to the industry to do it on a speculative basis. And after they've pumped billions into research, they feel they have a right to try and recoup it through IP protection and excessive pricing of what they have produced.
Isn't the R&D...
So we now need...
Sorry, Doctor. Isn't the R&D spend related to the fact that another area is not a public good? Our public universities are not offering education as a public good. There are currently huge monetary barriers to entry for poor students, and R&D is underdeveloped in the public sector because public universities are not quite investing enough in knowledge and in medical knowledge as well.
You see, if you go back, I said it's a state responsibility.
Yeah.
And if the states don't fund, the universities will now go into the marketplace to look for funds to do what the states do. So it's state dereliction of duty that is the primary problem. Because you cannot expect higher education to be free and research to be fully funded if it is not funded by the state and the people through taxes and revenues that the state collects. And it's a chronic problem of underfunding of research from budgets of the population.
Now, I've got a philosophical question here. Section 27 of the South African Constitution is also carried in spirit and in ethos in the Physicians' Pledge for South Africa. How does this stack up against what has actually happened in medicine, and that is the hyper-commercialization of access to medicine and to care and to health? How do we have such a beautiful constitution and a Physicians' Pledge and yet have a different reality?
Well, I'll take you back to the G8 countries.
Yeah.
If you look at the G8 countries, there's only one that has left its healthcare to the marketplace, and that's the United States. And they spend far more than anyone else with outcomes that do not compare to the expenditure. Now, all the other countries, Japan, Germany, France, they are capitalist systems, but they have national health systems, even though it's a capitalist country. The UK.
They have universal health care.
Because they create a national health system, that's where they create social solidarity. And they endeavor to come up with mechanisms where you get the care that you need, not based on your ability to care.
So they've got a form of a system where those who are able to subsidize those who are unable to in our society. But some would criticize this as socialist and be very critical of it on ideological grounds.
Well, I'm not a person for label. We can't be looking for equity and equitable access and then come with beloved terms, capitalism, socialism. You either create social solidarity, and universal access is based on solidarity. No solidarity, you cannot have universal access. The issues that we have been talking about in your inset about access to vaccination can only occur in the context of all lives matter.
All
And that we
lives
have
matter.
a system that recognizes that your need for healthcare services should not be based on which side of the tracks you are born, what your pigmentation is, what your economic status is. It should be based on need. And all of us on the globe have to have a compact about access to healthcare and the One Health concept.
I was speaking to economists about this issue earlier in the day in preparation for our chat, and they say actually some studies are saying that ultimately it's cheaper for the state to provide this access to vaccines, especially in pandemics, because the cost of treating a massive disease like this down the line with masses of critically ill people, the infrastructure is just not there. So you'd rather make people have access rather than treat those unable to pay down the line. What's your take?
My take is that it's not about it's cheaper for the state. It's about it's cheaper for the people. Because we, the people, are governed. And we are the state. Once you begin to have a separation between state, people, you begin to create a challenge. The state, that's the servant of the people, is not doing the people favor by ensuring that people have access to health. So we should disavow ourselves from this notion of making it state responsibility. We should see it as a collective responsibility of us as citizens. The state are appointed administrators that serve the people. I've never seen anybody that says, I am the state and I'm giving you money. States are constituted by collection of taxes from the people. So we have to clear our mind of the fact that the state is not our master. The state serves us. We organize the state. We vote, we put that state in operation, and we, the people, are the state. As long as we stay united as a people and we don't create classes of ruling classes, the state becoming a class, the state having its own health access and health facilities as we have in this country, that's a recipe for disaster, as we have right now. Your health will be in crisis, will be in tatters, will be expensive. It will make access to the disadvantaged and less endowed impossible, and you'll be creating a multi-tier healthcare system. You'll be having a state that is basically a perpetrator of human rights violation against the people that it is supposed to govern.
Thank you very much, Dr. Kgosi Lehlape. Thanks for joining us this evening, and thanks for those insights. And now, let's take a short break.
But Tans, how we are affected goes beyond numbers. In March 2020, you wouldn't have thought twice about hugging a friend or an elderly relative. Now, you hold back, unsure of the risk. And of course, there is the cost to the economy. Many people have lost their jobs, with many companies shutting down due to the lockdown, and with thousands fighting for the few that remain. That's why the news around the University of Oxford's vaccine trial, the Chinese trials, and the Russian vaccine effort are so welcome. Never before have we seen such encouraging results so early in the process. While we still have a long way to go with the Oxford trial before we arrive at a safe and effective vaccine, these results do give us hope that a vaccine is possible and that we are on the right path.
It's less than a month since Russia's Sechenov University began the first testing on 38 healthy paid volunteers. It said that some of them suffered headaches and fevers in the first 24 hours after being injected with the potential vaccine, but their symptoms resolved quickly. Now the scientists say the vaccine has been shown to be safe, and those patients are being discharged from hospital. They'll continue to be monitored as outpatients. But this is just the very first stage of testing on one that other vaccines around the world had already achieved. The researchers will now have to prove that their vaccine works as protection against COVID-19. They say that the preliminary results are positive, but they haven't released the data yet. The head of the centre carrying out the trials says that the second stage of testing has already begun, and the vaccine could be submitted for approval by national health authorities as early as August. It could then be offered to people in the general population, which would be the equivalent of the third stage of testing, as anyone who received it would be kept under supervision. But it's too early to say whether this is the silver bullet that many people have been hoping for. According to the World Health Organization, there are 19 different vaccine trials around the world, and just 2 of them so far have reached the third and final stage of testing, one by China's Sinopharm and another by AstraZeneca and Oxford University. Lucy Taylor, SABC News, Moscow.
The rest of the world, Katie Viney, her husband Tony and daughter Rhiannon are desperate for a coronavirus cure. But as a family, they've gone further than most to help in the search.
Our eldest daughter Rhiannon, who's 19, it was initially her idea to do the trial. I don't see myself as brave. I just think I'm fit and capable of doing this. And if we don't do it, and if somebody doesn't volunteer, we're not going to get a vaccine. And we need a vaccine because we want to go back to life as normal. I don't like this.
The Vineys were among the first 1,000 people to enrol in an unprecedented study led by scientists at Oxford University. Half have been injected with their new coronavirus vaccine, the other half a placebo that will be used for comparison. Work that would usually take years is being done in weeks. Having proved the vaccine is safe, researchers at Oxford are already moving to the next phase of trials, involving thousands more volunteers of different ages to further assess how well it protects against COVID-19. Millions of pounds has been pumped into accelerating the efforts of Britain's 2 frontrunners at Oxford University and here at Imperial College London, where a separate vaccine is set to be tested on humans later this month. On top of that, a rapid deployment facility is being constructed and a deal's been struck with pharmaceutical giant AstraZeneca so that if a successful vaccine is found in the next few months, it can be made and distributed in the UK and around the world as soon as possible. But experts say that is a big if, not least because the trial relies on people catching COVID-19.
We're right now in a phase where there are relatively few cases of COVID occurring, which is obviously great. But for a vaccine study, you actually do need cases to occur. And because you can't tell that the vaccine is protecting people unless somebody is getting it and the people who are vaccinated are not getting it. So that is a worry.
The UK is in the forefront of concerting international activity to try to deliver a vaccine.
The stakes couldn't be higher for scientists. Prime Minister Boris Johnson admits a vaccine or treatment is the only feasible long-term solution to return to the normality we once knew. The worldwide race to find a cure is gathering pace. It'll become clear in the next few months whether the UK is a real contender. Holly Hudson, SABC News, London.
And now the first clinical trial in South Africa and on the continent for a COVID-19 vaccine was announced on the 23rd of June 2020 at a virtual press conference hosted by the University of the Witwatersrand.
With our over 9 million coronavirus cases and hundreds of thousands of deaths worldwide, it's a race against time to find a vaccine. South Africa will now begin testing a vaccine manufactured at the University of Oxford in the UK. The first patient will be vaccinated today. As South Africa reaches the over 100,000 infections mark, we catch up with these patients here. Speaking exclusively to SABC News, they are being readied to participate in the first steps to saving lives in the country, the continent and the world.
It's a very serious thing. All of us, let us contribute and participate on this. I'm very happy today, even myself, to come here and contribute and participate on this. COVID-19 is for everybody to be concerned about this.
We also caught up with the principal investigator for the vaccine trial at Chris Hani Baragwanath Hospital.
This study in particular is what we call a placebo-controlled study. So even though we are enrolling 2,000 participants, only half of them will get the real vaccine. We reiterate this when we enroll patients, but on the day as well, we will reiterate with them, look, now you can get the real vaccine or you can get placebo, but you will not know what you receive. Okay. So the vaccine would come in a 1 milliliter syringe like this, which is prepared in the pharmacy, and this is empty. And then when we do vaccine trials in adults, we use the non-dominant deltoid to administer the vaccine. Because vaccines do have side effects, you can pretty well get a sore arm or feel a little bit unwell, and then you don't want to impair your arm's functionality. So we would ask the patient to just show their deltoid. We would wear gloves. This particular vaccine we are testing is a genetically modified organism, so we need to be careful when we're looking at the vaccine. So we would first clean the spot nicely, and then, I'm not going to take off the yellow, but we would stabilize the arm. We would inject slowly the entire volume of the vaccine, taking sure we don't have any accidental spillage. We would remove our needle. We would just dab with cotton. You can just hold there for me. And then importantly, what we need to do here is we need to put a plaster, because like I said, this is a genetically modified organism.
The trial will start off with the first group, who are people without HIV, that will receive 2 doses of the vaccine spaced 4 weeks apart.
This is basically to do an intensive analysis in terms of the safety of the vaccine, as well as in terms of its immunogenicity. Over the course of the next week or so, we will then start with group 2, which is a larger group of 1,900 individuals. And this particular group, at this stage, we're planning on giving a single dose of vaccine. But depending on the data that comes from the Oxford study, where a 2-dose schedule is currently being evaluated, we might or might not decide to actually include a second dose of the vaccine. This particular group is probably the most important group because it gives us a greater window of insight in terms of the safety of the vaccine, as well as whether this vaccine actually protects against COVID-19. So in this particular group, we're evaluating for vaccine efficacy. Last but not least is after group 1 has been completed, we will then embark on a small study in people living with HIV, really to see how they actually respond to the vaccine given 2 doses spaced 1 month apart. All of these participants will be followed up for 12 months, including having calls every 2 weeks to assess for respiratory illness. And if they do have symptoms, they will be investigated for COVID-19. In addition to which, throughout the 12-month period, all of them will be evaluated for safety in terms of any sort of adverse events that might occur.
Scientists say of concern now is vaccine nationalism.
Vaccine production is being ring-fenced for particular countries. And obviously the richer countries and the richer areas are trying to say, my country first and all my citizens first. So there's a very, very important global dialogue now going on about vaccine access, which says, actually, if we develop vaccines, these need to be available to all citizens of the world. There might and will have to be prioritization because the amount of vaccine available to begin with will be limited. And we might have to think about groups such as healthcare workers first. But what we are arguing is that it cannot be my country and my country only first.
On when it will be known whether the vaccine works or not is dependent on how quickly they accrue individuals who would have gotten infected with COVID-19. Criselda Lewis, SABC News in Johannesburg.
Tans, never before have I seen so much interest or focus on health science and research and ethics. Developing a vaccine in less than a year once felt like an overly ambitious and maybe impossible dream. The world's most experienced pharmaceutical companies have never been put to such a test. At the same time, we have to expose misinformation and conspiracy theories. Sometimes it can be an innocent mistake. Misinformation spreads so easily because it taps into our fears and doesn't need to include any truths. But the impact can be dangerous and damaging. First, it continues the belief that Africa cannot be a source of health innovation.
Now, Africa is genetically the most diverse continent on Earth. We need to ensure that the different regions in Africa are part of clinical trials as scientists and innovators press on. Now, my producer, Prudence Babazile Makubalo, reports on vaccines as a public good.
Since the first case of the coronavirus infection was detected in Wuhan province, China, in December 2019, the world has been scouting for ways to fight the pandemic. A vaccine has come out as a possible ray of hope, with steady developments being made by vaccine groups from UK and around the world. Before a vaccine is approved for mass deployment, there are many questions regarding its distribution. By promoting good health, vaccines help to increase cognitive skills, physical strength, and performances. Increasing investments in vaccination can potentially help keep people healthy and empower them to be independent contributors to society and active for longer. Vaccination helps to prevent productivity loss through illness and absence from work. 6 million working days are lost in the UK due to seasonal influenza every year. However, some economists are arguing that the development of a vaccine for COVID-19 should be treated as a global good in the sense that the benefits of an effective, tested vaccine have large positive externalities. Vaccination has positive effect beyond individuals and provides indirect benefits to the unvaccinated.
I think the other thing to recognize around global public health goods, as vaccines are, is that the outbreak pathogens don't recognize borders. And although one country may be able to vaccinate a high proportion of individuals and in fact even induce herd immunity in the country, transmission of pathogens cross borders and mean that we're all at risk when any country is at risk. And as we say, especially for measles, which is one of the most transmissible pathogens, is that measles anywhere is measles everywhere. And when we have measles anywhere, it means every country must continue to immunize and immunize at the rate that it does protect every individual in the community. And so we can't protect from pathogens, from germs crossing our borders. And that's why these vaccines have to be recognized as protecting the whole of the world and the contributions from every country to do that.
The hope is that billions of dollars can be made available on a multilateral basis to speed up the development, manufacturing, and equitable deployment of COVID-19 vaccines. This might follow the example of life-saving treatments developed to tackle HIV/AIDS over the last 20 years, with higher unit prices charged in higher advanced high-income nations, helping to cross-subsidy supply in developing countries. Prudence Makubalo, SABC News.
Well, thank you, Prudy. Now, there are more than 160 vaccines in various stages of development. Experimental shots from the University of Oxford with AstraZeneca, China's CanSino Biologics, Moderna, and a partnership between Pfizer and BioNTech are among the vanguard. For more on the vaccine and how South Africa will handle it, we are joined now by Dr. Phahla. Dr. Phahla is the Deputy Minister of Health, and I'm sure he's wearing many other hats at the moment. Good evening, Dr. Phahla. How are you?
Evening, Tandaka. Very happy to participate in this discussion and welcome interaction with you. Thank you very much.
Well, Doctor, you know, we just spoke to Dr. Khosile Tlhape, and we were talking about the dynamics between the public sector and the private sector with regards to the funding of vaccines, and particularly the COVID-19 vaccine. What are you working on? And what is in the mind of Cabinet about how exactly this is going to pan out between the private sector, the pharmaceutical industry, the R&D groups, and the state? How are we going to fund this?
Well, I hope that my network will hold. It looks like there might be some problems, but I missed you here and there. But essentially, agreeing with what Dr. Letlape was saying, our view is that a vaccine in the process of now the research, the testing of the vaccines, and ultimately when certain vaccines are confirmed, they should be such that all citizens of all nations of the world should be able to access. And therefore, that's why our approach is that of collaboration. We're working with various private sector companies, working through largely through the world-recognized bodies, like essentially the supreme body for that being the World Health Organization. But there are also other subsidiary organizations like Gavi, which has traditionally been the ones spearheading the research and development of vaccines. So these are very expensive research and trials, and therefore our approach is that it can't be something which is spearheaded by one particular nation and country. So we rely on collaboration amongst state actors, governments, and also private sector, pharmaceutical organizations, research institutions, working under the auspices largely of the World Health Organization.
Now, suppose a pharmaceutical multinational comes up with a very effective vaccine for COVID-19. Do governments like ours rush to buy enough of this vaccine and then distribute it and hand the money over to the pharmaceutical company, as we did with the HIV treatment programs? Or do we have a different way of approaching it this time around? Do we have any deals in place with those developers if they are based in in the pharmaceutical industry?
Well, what I'm aware of is that those discussions are actually happening. We are in discussion with the various bodies which are involved, and the idea here is that with the view that once any of these trials are successful and particular vaccines are confirmed to be effective, they should be available to people irrespective of their income. So there are upfront discussions which are happening as we speak. Some of them, through Gavi, through individual, some of the companies which you have mentioned, under the auspices of the WHO. Earlier on, you have Prof. Shabir Mahdi explaining, and also one of our professors, Professor Helen Rees as well. So that's why we have our own South African, academics participating in the development, in the trials, but also discussing with those who are likely to produce any of those vaccines upfront, so that they can be, we don't wait for the day when the vaccines are actually confirmed.
Now,
without being able
Dr. Pasha, bear with me for a moment. Let's talk about the government patent office, the registry of patents in the country. Suppose do you agree perhaps with Umunyana Rigege, the executive director of Section 27, who with other groupings seems to be suggesting a moratorium on COVID-related patents, whether they be vaccines or treatments? And that moratorium would give government time to see who owns the intellectual property and how to ensure that every citizen has equal access to these life-saving treatments and vaccines. Do you agree with a moratorium on COVID patents?
Well, that would be very ideal, Tandeka. A moratorium on patents would suit us, those of us who are responsible for providing health services to the public. That would be very ideal, but in the real world of capitalism, while that would be ideal, indeed, we also are aware of the fact that the companies argue that they're going to put a lot of investment into the research, into the development, a lot of equipment, and so on. So I agree with her that that would be the ideal. But if we're able to reach that kind of agreement, that will be superb. But being aware that we may not, we also have to look at Plan B, and that's why ongoing discussions trying to get the best for the public.
Finally, talking about real life issues, there are real concerns that with HIV there were stock outs and there were distribution problems with ARVs, and also the concerns about government corruption and tenders. Will this program of making sure that citizens actually get life-saving treatment also become immersed and drip with corruption, as did the food parcels and the PPEs?
Well, definitely we're doing everything in our power to make sure that that should be avoided. As you are aware, even in terms of the current issues which are in the public space, the president just today announced an intervention through which a cabinet committee will be probing all that, and he has already given the mandate to various agencies of the state to probe and leave no stone unturned. But in this regard, because not that others were not so important, but we have learned from our previous mistakes and loopholes. So we will do everything possible to make sure that when this happens, when the vaccines become available, tested, and can be proven to be efficient, we will make everything possible to make sure that they reach the people and that no one is left behind.
Dr. Pasha, thank you very much for joining us this evening. Thank you. Much appreciated.
Thank you very much.
Now, a great conversation that was with the Deputy Minister. Don't you think so, Nana?
Broader success will ultimately mean more than crossing a finish line. It will mean we as a society have the wherewithal to produce, provide, and to pay to protect ourselves from COVID-19 and other coronaviruses that could one day come. Many influential voices have spoken out about how a COVID vaccine should be an economic public good. Good night.
Good night, everyone. Till next time. Khonandin Mawet.